My name is Rebecca Guy. Guess what? I'm from the Kirby Institute, in case you hadn't guessed. So I'm very pleased to be the chair here today for the Kirby seminar series, and particularly to be able to introduce Asha, who I'll introduce in a moment. Before I do, I'd just like to acknowledge the traditional owners of the land, which is the Bidjigal people. I'd like to pay my respects to elders past and present, and to warmly acknowledge all First Nations people who are here today, and also everyone who's joined online and the lands from which they're joining from today, which is diverse, reflecting many people at the Kirby Institute, and our collaborators work in many remote places across Australia. So our seminar today is based on a topic we haven't heard much about at the Kirby Institute, and I'm sure you're all very excited to hear from Asha. I know, just jumping to the fact that I've been able to collaborate with Asha in the last couple of years, I think every meeting I have with Asha, I learn something new, and I'm sure you will today as well. She's very generous and a wealth of knowledge, and I think today will be an excellent seminar that you'll all enjoy. But more formal introductions for those who don't know Asha. Asha is a clinician scientist, and she's a paediatric infectious disease specialist at the Perth Children's Hospital. And based there, she leads the healthy skin and ARF prevention, so acute rheumatic fever, at the Kids Research Institute. So you probably would have formerly known that as, be aware of that being known as the Telthon Kids. Asha, being an infectious disease physician, she does contribute a lot of infectious disease knowledge to the sector and leadership in that space, and with a particular focus on child health, and particularly working with vulnerable populations, and has done a lot of work in remote First Nations communities, which she'll tell us a lot about today. And she collaborates with us on the point of care program, but also neglected tropical diseases. So collaborates with many of us at the Kirby Institute, which is fantastic. And Asha would not say this about herself, but she's got a lot of accolades, which I think is important to read out, because often as a person, you don't tend to say these things. But Asha was recently in 2024, she was recognised for outstanding research in the 2024 King's Birthdays Honours List, which is very few people, so something to be congratulated. She received an investigator grant, also elected as a Fellow of the Australian Academic of Health and Medical Research, and appointed to the Research Committee of the WA Futures Health Research Innovation Fund in 2024. Phew. So very pleased to introduce Asha, who's going to talk us through her work. Asha, if you wouldn't mind coming up, and we'll set you up with the slides. For those of you online, if you could put your questions in the Q&A box, and once Asha's finished, we'll get to the questions and have a good discussion around about 1:50. Thank you.
Awesome. Thanks, Beck. And thanks everyone for joining in room and online. I am very impressed with the online attendance as well, because on the screen it looked like there was 2 people, but there's actually 41 on my screen over here. So Beck said there will be people everywhere today. So thank you very much for the invitation to come to Kirby. And it is lovely to see many familiar faces in the room, and hopefully to meet new people as well. And the topic that I was sort of thought to speak about is around community engagement. And so it's not necessarily around specific infectious diseases, but much more about the process that we follow in order to ensure community engagement. And I think that's everything. So I'm mostly going to talk about the STOP and the SNAP trial. I also want to extend that acknowledgement of country and recognise what a privilege it is here in Australia to have working on country that has always been stewarded for millennia by Aboriginal and Torres Strait Islander people. And I choose a different slide every time, but I really do like this one to recognise the many, many, many different language groups, recognise the huge privilege that I have had to learn from people from many of those different language groups, and that continuity of culture connected to language that we need to continue to support and encourage in this country. So this week was National Close the Gap Reporting Week. There are many things that are not going right. I hope I can bring some stories of things that are going right and changes that we have been able to make together in partnership. So you know, you get your disclosures and everyone flicks over really quickly. But I think actually it's a nice thing to think about. What is the positioning of the person who is presenting today? Not just about what the science they're bringing, but who are they? And so, yes, I'm a clinical trialist and I can own that phrase, and we'll talk about 2 clinical trials. I think probably more important to me is the values that I hold and the values that I hope are reflected in the work that I present. And then also sharing our values, we can also identify those people who are going to be great collaborators we want to work with. So equity is a really strong driving force, making a difference, collaboration, inclusivity, and compassion. And so those are things that I try to bring through in everything that I do. And I'm more than happy for people to call me out when those aren't showing up, because all of us have those moments where we're not necessarily playing to our best. And I think it's great to also challenge people. I'm a lifelong learner driven by curiosity, and I threw these photos in for 2 reasons. One is it's International Day of Women and Girls in Science. And so for all the women in the audience online and here, awesome for being great scientists. And for all the men in the room, thank you for encouraging this, because it's something that 10 years ago, the UN General Assembly decided was a really important piece to encourage that pipeline of women researchers to demonstrate to young kids like myself in that little photo, a curious little being who was looking around the world, wondering how to make sense of it and wanting to know what I was going to be, that a woman in a lab coat is okay. We don't always see it, and I don't do a lot of work in the science lab, to be honest, but that photo was taken. But to really celebrate today as a day of International Day of Women and Girls in Science. And then I am a passionate paediatrician to advance child health, but my most important children in my world are my 2 kids shown in the final photo. And that's on country all the way up on the Bardi Peninsula, north of Broome. And we were recording a hip hop video and doing some research, and my kids came along for the ride. And so it's great to have them complete in Telethon Kids uniform, which they quite proudly put on. The shirts are a little big, the hats fitted quite nicely, but that's kind of part of my lab now, is working in remote communities and always trying to bring both my research team, my children, everyone together to walk forward in the journey. So something Aboriginal elders have taught me along the way is that we are the people we are because of the people who shape us. So these are photos of my family. The other story I wanted to talk about, the 11th of February, is it's my mum's birthday. And so I was very grateful to get the opportunity to come and talk with you today, but it also means I can have dinner with my mum in Sydney because I came from Sydney. So a huge privilege to be here today. And we'll catch up with my sister and my nephews and other parts of my family tonight. So these are the people, I guess, who've shaped me, who continue to contribute to my world, and definitely love that my community takes a photo of us on Mother's Day every year. So a great one there. So how did I get into the type of work that I'm going to be talking about? And I grew up in Sydney. I went to school here. I then traversed down to Hobart into a Bachelor of Arts down there on Palawa country. And then like my school was in Darug country, and then I moved back into the city and was on Gadigal country, trained at the Sydney Children's Hospital, and it's lovely to have some colleagues from there today. And then thought, okay, where in the country have I not really had a chance to work? And so I went and lived on Larrakia country in Darwin, and I thought I would be there for a really brief amount of time, learn a little bit about Aboriginal health issues, and then take off and save the world and do HIV research for the rest of my career. That was my vision. That was my goal. That is not what happened, and I'll unpack some of the reasons for that. But I think that the needs for Aboriginal child health research and the opportunities that I had in my hand were the 2 things that went together. And with a lot of training and stewardship, really privileged to be able to now work almost completely in Aboriginal child health. This is one of the clinics I worked in. A camel came to visit us. I ran out the back door to take a photo because I thought, when am I ever going to see this again in my life? I think that was in Docker River down in Central Australia. And then another photo of some of the very, very remote communities. I then moved to country Wajak Noongar Budja in Perth, and got to, I guess, extend my infectious diseases career, but also work on a lot of research. And the photo of these 2 little Noongar boys is from the first hip hop video we recorded, and that was on Healthy Skin many years ago now. But I guess it just exemplifies some of the things that I'll talk to. And then most of my research is backwards and forwards in the Kimberley and Perth. So that's where that's highlighted as well. So Yaru country, but many, many language groups represented across that. So I think many of these stories are important to kind of go, actually traversing around the country, all of these different language groups have unique identities and unique things that we can learn from them. And it's been a real privilege to learn for myself, as well as that journey in thinking out as a non-Aboriginal person, how can we best champion the cause, enable space to bring Aboriginal leaders through and forward, and creating a better future for Aboriginal child health. So I do come from Perth. This is the beautiful Derbyl Yerrigan, the Swan River that flows through the middle of Perth. And then this is my team at the Perth Children's Hospital. They do look pretty awesome. And that infectious diseases and immunisation team. So really founded based in that clinical activity. And that's one end of the Perth Children's Hospital. It looks quite beautiful. And those are the wards for the children who stay there. And then the other end of the building is the Kids Research Institute. So we have the 6th and 7th floor as the research component of the Children's Hospital, which is floors 1 to 5. And that's where I get to lead these amazing people who contribute to all of the research that I'll talk to, and lots of photos of us with Aboriginal elders, learning on country, creating hip hop videos. I think the coolest thing that I ever get to spend money on for a grant is a Land Cruiser that you can drive across all of these corrugated roads. So that is one that we continue to own. And then we get to work with the Starlight captains in different research projects. So lots of fun. The kids' bridge that you can see in the bottom of the photo of the buildings takes us across to Kings Park. So it is a beautiful location to be, and to be able to get back to nature very quickly during the middle of the day. So I'm going to talk about 2 clinical trial stories, and really to try and exemplify inclusivity and engagement. I'm going to talk about the STOP trial, which is one that I've led, and it's a really long journey. So I'm going to try and summarize it as succinctly as possible to get to the key messages. But it really has been a journey of how to involve community leaders along the way and continuously position yourself in that curious learning space where you're not the expert, but you bring an expertise, and you're inviting in expertise from others so that you can co-design and collaborate there to improve outcomes for kids. And then I'll talk about the SNAP trial, which is a network adaptive platform trial, which some of you are investigators on and will be very familiar with, but I heard that people were interested about that topic as well. And so just the one point, I think this new guidance from the WHO on clinical trials and clinical trials design really fits well with this concept of community engagement, making sure that we're as respectful and involving of communities that we're trying to solve questions for, not just about them, but with them. And so I was really quite excited when this guidance came out last year, and hopefully it will continue to enable good clinical trials. So the STOP trial. Most of my work is in skin health research. And so that's about skin sores and scabies and how to get rid of them, essentially. And so we designed a step wedge cluster randomized trial back in 2015, 2016, and it's taken almost 10 years to do this work together. So it's been a very slow journey. It wouldn't have been possible without the considered partnership, which was foundational to the work. And so that's where the Kimberley Aboriginal Medical Service, Nirrumbuk Environmental Health and Services, and WA Country Health Services all sat together and decided to support this work because it was a common priority and that we wanted to work together. And I was awfully grateful for that with the Kids Research Institute on the left of the side. That we decided things like we put our logos together, and we made an agreement that our logos could always sit together underneath the STOP trial logo. The STOP trial logo was chosen by our 2 lead Aboriginal partner organisations, and we really privileged their voices in making decisions about how the trial could run to enable that, I guess, strong leadership to come through. But it went all the way through COVID. And so there were really a lot of tests and challenges along the way. And so some of those key decisions to position our logos together, to keep coming back to each other, and to have partnership steering group meetings and allow that to be the common decision-making ground was really powerful. And I'm so grateful that we had the wisdom to do that, because it really was tested, and we needed that as we went through COVID as well. So something that I think became more and more clear as we were going along the journey was that the way in which we were wanting to communicate health messages within the STOP trial really required us to learn more about Aboriginal ways of knowing, being and doing. And some of those themes that kept coming through were that artwork, story, song and dance are the 4 key ways that Aboriginal history and narratives are communicated in community. And so we were like, well, let's commission an artwork. Never done that before. That's a cool use of NHMRC funding, I think. And so Luke Richards came along, and he's a Bardi artist, and he produce gathering circles. And so hopefully you'll see this a lot through the rest of the talk, but it will make sense to you. There are 9 communities involved in the trial. They're all quite unique, and you can see that they're represented by circles on this artwork that are all coloured differently. So that represents their uniqueness. The kids sitting around the circles are represented by the hands. We were focused on skin infections, and every time we spoke to the kids about skin infections, they drew hands. So we were like, there's something here, we better include it in the artwork, and it's obviously in our logo as well. The country traversed, like the communities are connected, but they're unique. And there are beautiful coastlines and beautiful, beautiful ochre landscapes. And so he was able to bring all of those things together in the artwork. So kind of a cool story that can tell the story of the STOP trial, but we were able to use it in a way that acknowledges his artistry and his skill set, and then also get the contracts that were able to pay for the work and then enable it to be continuously used. And that was something that was also really critical to embedding artwork into our work. Wasn't just to assume that it was okay to use it, but to actually contractually set it up so that we had that respect of his knowledge and his skill set throughout the journey of using this artwork, and continue to be in contact with Luke and appreciate his skills. So the STOP trial was a big endeavour. We wanted to see if we could reduce skin sores and scabies by 50% in remote living children. And so we decided that we would use a cluster randomised trial model. So there were 4 clusters. It was the minimum number of clusters we could possibly put into this design to answer a question with the amount of people that we had available to us. So there were limitations everywhere. So anyone who's really honed in on methodology, please forgive me. There are, like any cluster randomized trial, you should have probably 20 clusters. 4 is very, very modest, and there's 1 step in the design. So it's not as rigorous as it was possible, but it's as rigorous as the community was able to support within the Kimberley region. And so the Kimberley Aboriginal Health Planning Forum chose the communities, chose the clustering, and chose how this was going to roll out. And so it's always limited, but it is the best that we could do. And so we chose some from the east, some from the west, some were accessible via, I guess, a paved road drive. Many of them were accessible by highly corrugated red dirt roads that were, I think, fun to drive on in that 4-wheel drive, but also like you actually got a workout in that kind of shaking experience of driving it across the absolutely beautiful country. So another key thing, you can see this STOP trial artwork again. What we also did as we're progressing, Indigenous data sovereignty became more of a stronger voice. I think it's always existed, but I don't know that it was impacting researchers as powerfully as it is today. And so what we wanted to do with our results was to bring them back to community first. And so we tried to think of ways that we could do that. And one of the ways was to use a graphic facilitator. And so the graphic facilitator and his artworks will be sort of throughout the rest of the talk. And this is just one stage which tells you that the trial took a really long time. The actual study started in 2019 and finished in 2022, but the time taken to prepare was about a 3-year journey to get the ethics approval from 6 different ethics committees, to get all of the partnership pieces in. The partnership steering group wanted Aboriginal people to do all of the consent, which is not something that we designed for, nor had we budgeted for. And so as a CAA, I was like, okay, don't know how to do that, but yep, let's have a crack at it. And we were able to train up staff from the Nirrabuk Environmental Health and Services, and they consented the 915 children involved in the study, which was amazing to be part of. And many, many, many moments where you're like, I think this is the right way to go. I'm not really sure. Let's have a crack at it and we'll learn together. So really thank Vicky O'Donnell and Ray Christophers for pushing us to that limit to embed that, because I think it made it a much safer trial for children and families to participate. I think it increased the participation rate, but it also meant that we all had to work together and figure out different ways of doing consent that we'd never encountered before. So that was back then. Then we did the study, and then it took a while to, I guess, analyze and share results with community before we wanted to publish them as well. So we wanted to give the community some visual story about why we started the STOP trial, what was going on, because quite often living in community may not necessarily know what researchers and health leaders were thinking about and what was important. But there was outbreak of glomerulonephritis, and about 120 kids across the course of 3 years had glomerulonephritis. And so that's what really pushed the leaders to go, okay, skin health is clearly on the pathway. Strep A in the skin leads to glomerulonephritis. We need to do something about it. And we knew that from other research we were doing that skin sores were being normalized. And so we had some sort of key pieces of data to say there's something that we need to do here to pay attention to. So this is another way of saying that same story. Skin health really matters. And sadly, in Australia, where we have some of the best resources for healthcare, Aboriginal children living in our remote communities have the highest burden of skin infections in the world. And so their world leaders in impetigo prevalence, and that median of 45% is actually 1 in 2 children in a classroom at any time with skin sores. And so that's not the incidence, that's just the prevalence. That's every single day of the week, there's going to be 1 in 2 kids in a classroom with skin sores. So the transmission potential of strep A and staph between kids is extremely high at that rate. And that was a systematic review I did in my PhD, which bamboozled me. I was like, how is that possible in this high income country when rates in Africa and Asia were probably around 10%? And from all the studies we compiled, and then in Oceania was about 30%. And we see that is really high. So how is it possible and what can we do about it? And so probably drove me to not keep thinking about HIV, but to actually keep on this journey of looking at healthy skin. And there's lots of downstream consequences that we want to pay attention to. And that, I think, is what I do in my infectious diseases work at the hospital. But I really wanted at that community level to think about how do we prevent kids from coming into hospital in the first place. That's how we tell the story to the kids. Skin sores and scabies cause bad sickness. And you can see pictures of the sores. You can also see that the different organs of the body are sort of demonstrated in cartoon character so that kids could get a sense of, we're not just worried about the sore on your skin right now, because that's a problem, but we actually want to do something about some of the other things that can occur. So the Kimberley leaders and I guess the researchers actually came together at the right time where funding became available to put this together. And if I was just on my own doing it, it would have been the STOW trial. It would have been See and Treat, or the SATCH trial, because diagnosis and treatment is core business for infectious diseases. I didn't think hard about how you could incorporate P as prevention. And I know it's definitely part of our public health frameworks, but it often doesn't find its way into clinical trials. So clinical trials around public health frameworks are much rarer, I think, than around diagnosis and treatment. So I'm really grateful to the leaders who said, everything we do, we have to have this prevention aspect, because we don't want to just reduce the rates. We want to stop it from happening altogether. And so they were very clear. We don't just need new medicines. We need prevention. So these are the 3 components. We see skin sores and scabies, and all of the checks were done in the school. So that's why we had so many ethics committees, because we had to get permission to work in the schools as well as in the health settings. But we knew that's where kids would be. We knew that the schools were also worried about skin sores and scabies as it was impacting on kids' ability to learn, and they wanted to do something about it. And so we had to work wherever there was space. And so this is kind of like the school library staff room, sort of the only large room at this particular school. They let us set up a little lab there, and we got to do lots and lots and lots of skin checks. We also were trying to influence treatment change at the clinic level. And so 2 key studies were published just before we got started. And one was a skin sore trial that I led in the Northern Territory. And we found that cotrimoxazole and drink medicine was just as effective as the needle medicine. So great news for kids that they didn't have to have a painful injection every time they had skin sores. And we really wanted to try and get that evidence into practice. And Lucia Romani led the trial, the SHIFT trial, with many others in the room involved in that, and showed that ivermectin was more effective than likely for treatment of scabies. So we were trying to get these 2 pieces of evidence into clinical practice. And so we weren't generating new medicines. We weren't looking at different things. It was a comparative effectiveness. How do we get the medicines that we know work into clinical practice? So going beyond sort of that, we know they work, into implementation science. And then the prevention component. And prevention we did wherever we could. We used, the flag. You can see the artwork again. We sat on basketball courts. We yarned with the elders. We definitely had a lot of feeds, and there was always dogs everywhere. So that was a lot of fun. It was mostly focused on health promotion and environmental health. So this is like the step-word cluster randomized trial design. Every single community of the 9 communities was visited 10 times over the course of the 4 years of the study. One thing you should never do with a cluster randomized trial is stop data collection, but COVID happened and we had to. So there's 2 visits that were cancelled. We had to redo our analysis plan, go from a frequentist analysis to a Bayesian analysis to try and take account for this. The statisticians scratched their heads for a really long time and said, you've got too few clusters in one step and it's not going to work and it's not going to work and it's a disaster. And I'm like, hold tight, we can do this. It will be okay. And it turned out to work, but it did require a lot of collaboration. And so we had to repeat step 1, as you can see from that, and then step 2 as well. So a really typical design that's used, I think, a lot for that implementation research to get things into practice as quickly as possible. So now I'll focus a little bit more on like exactly what we were able to collect. So there were 915 children. We did over 3,000 skin checks across the 8 schools for the 9 communities. And we did a lot of qualitative research as well. So that was partly around the health promotion, environment health, but also to find out what was working and why and what the community perspectives were on it. And so I think there was a lot of two-way learning that happened across this piece, because you can't yarn with community without getting to know. And that led to trust formation and opportunities to learn more about what was going on there. Over 1,000 swabs were collected, 45,000 kilometres of driving across the Kimberley. We had about 60 travelling team members and volunteers who participated at some point. And it was a great opportunity to bring HDR students in, medical students, lots of other people who wanted exposure to health in remote contexts and were able to participate. And then we did an enormous amount of training. Almost 400 people were trained in the, recognition of skin infections and then the treatment that we were hoping to implement. And then this is the money slide. And it's not the statistical analysis slide, but it is what we achieved. So at the start of the trial, about 4 in 10 children had skin sores, and by the end it was 2 in 10. And so when I was trying to think about like, how do you communicate science in a community, this was the way that we could sort of start to make sense of it and help people to understand. And so that 50% reduction happened. The statistical significance of that is probably 0.3 or 0.2, something like that. So it's not perfect, but I think there's something that the communities are incredibly proud of, that something that had been stuck for about 5 decades had finally reduced through this collaborative approach. And we also found there were very low numbers of scabies. Setting out, we thought that we were going to see this 35% prevalence, and it was below 10% at all of the community visits. What we did find was lots and lots and lots and lots of head lice. And so now trying to think about what we do about that. We're only checking kids' skin health, but the community visits dramatically increased as soon as we started. So just this focus on healthy skin led to more people coming along. We also then heard from the community that giving parents a choice of their treatments was actually really powerful. So what we were trying to do was push clinicians from one old treatment to a newer treatment that we thought was more effective. What we actually found was the community really appreciated the fact that there were these 2 options and that clinicians knew more about the 2 options so they could be involved in the discussion. And so we've had to keep on communicating that message to make sure that that's not forgotten, that it's really important to involve our patients, consumers, in the decisions that affect their healthcare. And so that was something that kept coming through. Having bush medicine available was critical, and they really wanted to have their bush medicine alongside Western medicine. So in all of our books, we have both of them represented, depending on the community there. Everyone wants school health nurses, and they're such a valued asset in community, but it's a really contentiously funded situation. And so we're now trying to work on the policy to change some of the settings to enable this to occur, because the schools want it, the clinics want it, the families want it. It's the position that gets removed as soon as there's a crisis or a reduction in healthcare providers in a community, where they get back into acute care rather than that prevention framework, and skin checks should continue. This co-design of health promotion resources involved more than 85 community members. So Tracy McRae, who is shown, I think she's in the Akubra hat cooking the sausages on the far right in a Stop Trial shirt, is the PhD student who led this. And she's really developed an incredibly grounded methodology around community participatory action research and how to develop these resources together, of which these are some of those that we developed. And They're all in the very local language of the community we're working with. Some of them, their language had never been written down. Some of them, the Gidja language on the sort of left-hand side, have just published a dictionary. So we had access to the dictionary to look at checking words, but for some of them, we were writing on those big pieces of cardboard together to try and figure out, okay, how do we say this word? And there'd be a lot of arguments about whether there's a D and a J or a J and a D, and lots of different things about how do we write this word. And for one of the communities, I think it's the first book that they've ever had in their local language. So a huge gift, I think, back to the community, but also a gift to us to be able to represent a healthy skin message in a way that matters for community, and then can be, it's in all the schools and the clinics. We gave them to every single child who participated. We've really tried to distribute these books to communities so that they can identify photos of themselves in them. They can have messages that make sense to them as well. I need to go faster. So we also, I talked about artwork and a story. So we've covered those two. Song is an important piece. And so we worked out very early on that they wanted an environmental health hip hop message. And so in the midst of COVID lockdowns, we actually had the privilege of working with 45 high school kids. And we worked on teams. We wrote the song together on teams and then came together for a youth empowerment camp on the Dampier Peninsula and got to record it. And so I can't play it for you today because I didn't know if I'd get the tech exactly right. But if you want to look it up, Hip Hop to Stop is a cool one to listen to. And I think the beauty of it is seeing the country, seeing the kids, and listening to the healthy skin messages, but something that continues to last. The environmental health themes that came through constantly are really simple and straightforward. The living conditions in homes and communities in remote Australia are unacceptable. And the community knows it. They want change. They want to see better maintenance, and they want to see more investment there. And I think a trial like ours helps to elevate that message in lots of different ways. So we're hoping to use most of the qualitative data, which is still to be published, to be able to communicate those messages. We also learned so much from community. I think I've referred to this, but my team just had the best time being invited onto country. And, you know, as the lead researcher, I sometimes had to consider, okay, do I need to collect data today? Or is it okay to have a data light day and our team actually learns more about the country that they're on? And we had to make some of those decisions, and sometimes those decisions were made for us, and the school was closed, and you know, we went out on country. So lots and lots of opportunities, and I'm very grateful to the elders who allowed us to share these images, and some of the wonderful women who we worked with for the women's camp who are shown in these photos. And they wanted to have a healthy skin message at their annual women's camp, and so had more opportunity to participate there as well. When we came back to community, I've talked to some of these results, but it was really powerful to use a graphic facilitator. And probably many of you in co-design workshops or even any workshops have had graphic facilitation, and it really equalizes the playing field and helps share ideas and helps you test ideas, because you see something drawn up there, you go, oh, no, it's not quite exactly what I was thinking, and someone else will change it. And so our graphic facilitator traveled with us to every single community to sit down and yarn about the results well before we told the other investigators or even we published the results. So we really wanted that voice embedded into our analysis and into our reporting of the results. And so as far as we're aware, this methodology hasn't been used in research before. And so we are writing a paper on that as well so that we can bring that forward. So these were the kind of end outcomes, the sort of printouts of this was the important themes that came through when we were yarned with the Warman community about what they wanted to see. And then eventually we told the rest of the world. So we did publish these papers, and they're picked up in some of the Lancet journals. And it was great to actually finish the story and publish the papers. As a scientist, you know, that's kind of our metric. That's the thing that we want to do. But we were really delighted to be able to work with the editors to look at the way in which we embedded some of the community voices into the outcomes. And so if you do want to have a read and you want to learn more, please go looking there. You will get a lot richer on the methodology than I shared fully today. And then we tried to make sure that these messages weren't just for the communities that we were working with. It wasn't just for the scientific community, but that was reach into the public. And so we're really grateful for the media pickup and the ability to share the story more broadly across Australia. Then what we've done is use this data, and we're iteratively using the results to update the National Healthy Skin Guideline, which I'll talk to a little bit. But the thing I wanted to share was that actually now the Kimberley has its own evidence-informed, with their own local data, guidelines. And so that's the last piece where it's really gone from using data that's collected globally to inform their evidence practice into local data. So I think it's been really exciting to see that happen as well. These are some of the resources. If anyone does want to download any of them, the QR code, you can pick up your phone and scan it now. But the National Healthy Skin Guideline tells us how to manage skin infections and recognize them. But there's a quiz if you want to test your knowledge. There are fact sheets if you want to use them in clinical settings. And there's these health promotion resources as well. So lots of things there. And coming soon is going to be a strong skin app. So really trying to make sure that our research is reaching to the community where it's wanted, because the community said to us, we want an app. We want to be able to access your resources. We want to be able to see photos of different types of skin conditions so we can test out whether this needs to go to clinic or not. We're like, okay, we can do that too. So we'll launch that probably in a month or so. So moving on in the last, I guess, 5 to 10 minutes, we're going to have to do this one really fast. The SNAP trial. So changing pathogens, strep A to staph, SNAP, and then SNAPy is the pediatrics and youth component. So a network adaptive platform trial. And so this is why it matters. So you're seeing this figure, a slightly different version of it again. And really, if you don't get skin control happening, you're going to see Staph aureus bloodstream infection, and you're going to see the other downstream consequences. And so skin control, in my mind, is the most obvious thing to be doing, because it's easier to look after the skin than it is to be managing someone who's critically unwell in an ICU with Staph aureus bloodstream infection and has that high mortality. So that's kind of the link between STOP and SNAP. Staph aureus bloodstream infection, for those who work in the field, is the most common reason for community-acquired bloodstream infection in children. It leads to a lot of ICU admissions, but it's actually bread and butter for the infectious diseases consultants in the room. We see a lot of Staph aureus bloodstream infection, and yet fewer than 300 children ever randomized in a clinical trial to answer how to do it, and not a single one randomized to the common antibiotics that we use on a daily basis for susceptible staph. So similarly in adults, less than 3,000 adults. So this bread and butter condition, we actually didn't have the evidence for how to treat it. And so infectious diseases people across the ACID community came together and said, this is a top ranked priority. We want to design trials around it. And so fortunately, I was working with the lead investigators at the time and had the privilege of sort of stepping in as a pediatrician, say, but how about the kids? Let's get the kids in there. Let's not miss out anyone, because we could easily have done it from 18 and above, but we use the same antibiotics. So wanted to make sure that we're able to advance evidence, not just for adults, but also for children. So we knew it was an everyday infectious disease, and we can see from this data, the most important point is that vaccines were preventing meningococcal disease, pneumococcal disease, Hib disease, that were common causes for admission to the ICU, but there was no change in the Staph aureus bloodstream infection rate. We also knew that there was a lot of similarities between adults and children, but there are some significant differences. And the biggest challenge, to be honest, in designing this trial has been the mortality difference. So much more likely for adults to die than for children to die. And looking at this data, just want to acknowledge Brendan put all of this together. So a shout out to Brendan as an awesome collaborator as well, to be able to understand. This was the first time we really had a good handle on what is the mortality for children with Staph aureus bloodstream infection. So lots and lots of challenges, but some similarities. So when you're working in a hospital, essentially you're offering random care when there's a lack of evidence. It's an evidence-free zone. You're kind of like guessing which is the best thing, or you develop a preference, or someone trains you to be choosing a particular antibiotic, but it's random care. And it's probably not even probably, it's not the best way to continue to be in a learning health environment. So we wanted to build in randomized care, and we also wanted to recognize that we constantly extrapolate from adult data for children and wanted to stop that. So we developed this platform trial, and Josh Davis and Steve Tong, Josh Davis from Hunter and Steve Tong from Doherty Institute, are the two CIs that are leading this and have been really, I guess, gracious in allowing in everything from neonates through to the elderly. So you can come as a X24 weeker and be in the STAT trial, or you can be 100+ years. And I think the oldest person is 100 and the youngest is a 25 weeker. So we've traversed this enormous diversity. And so essentially, I'll show you the design of the platform trial, but it's just, you're building a research infrastructure. You're building the ability to run a lot of clinical trials all at the same time with the same patient population to improve your efficiency. But because you're then using adaptation, you're able to build in different comparisons that would otherwise be almost impossible to do. So this adaptive process is happening every 500 participants. And so we're looking at the data, we're analyzing, and then able to consider whether we continue or not. And so this is the trial structure. There's an antibiotic backbone domain. For those who know staph, there's MRSA, which is methicillin resistant, and there's two other types of susceptible staph. And it depends on what kind of susceptibility profile you have as to which antibiotic you want to use. But there's some simple antibiotics that we've never known which one was best. There was some observational data that gave us an idea that maybe one was slightly better than another, but that was not randomized. And so there was obviously some biases that could be in there. So we wanted to randomize to these antibiotic choices. We also wanted to know if extra antibiotics would add any benefit. And as an infectious diseases specialist, there's always this temptation to add more and to do more and to not, I guess, limit and to sit on your hands, I think, and not to prescribe another antibiotic is one of the harder things to do. So adjunctive clindamycins come into a lot of treatment options. And so we wanted to evidence that and to see whether it works. There's an early oral switch domain, and there's now a diagnostic domain. So two antibiotic treatment options, one strategy, which is early oral switch, and then a diagnostic domain. But it's built the platform that we can keep on expanding to the right and add more domains as the ideas come about or as we answer questions. It was really important to have kids in there because we knew that almost always there was no evidence for kids. And many times over, when pediatric randomized controlled trials were started, they were too small and had a difficulty accruing data, and so were stopped early. And so it leaves us looking at the evidence for adults and going, does it apply or doesn't it? Do we have the same things, or is there something that could be different about kids that leads us to pay attention differently? So that was kind of the evidence gap. And so we thought about a few different ways of doing this. Should we let the adults generate the data first and then try and run a pediatric trial? Well, that's an option, but we'd probably be another decade down the track and people would be saying, well, we've got this evidence, why do we need another trial? Should we do two sort of parallel trials? We could do that as well, but the idea of doing parallel trials I think would probably mean that one would answer the question much faster, and then we'd be stuck with this sort of stopping early because we haven't been able to answer the question. And so what we eventually did is go for a unified adult pediatric Bayesian trial, which has tested all of us to the limits of statistical analysis programming, has really, I think, pushed us to be incredibly clear and then to find our gaps and to try again and to improve on things. But I do think it's the way to go forward. And I think it's a model for infectious diseases research when you're trying to figure out what treatments work and why, to continue to involve that whole of life perspective, especially when you're using the same antibiotic for the whole of life. If you're using different ones, then it doesn't make sense. If you'd had really different outcomes, it doesn't make sense. But this does work. And so we have published a perspective on this to demonstrate the importance of it. And so Bayesian methods, as I said, the statistical wheelhouse for this trial is quite large and does require statisticians from across the world to work together to be able to add the benefits. We also had to go with, okay, the primary endpoint is 90-day mortality, and that's what we've chosen for everyone, but I've told you already that there's differences between children and kids. And so there's a concept of borrowing across the two different age groups to be able to answer those questions. I can't give you more details than that. You have to sit down with a statistician because all of us just have to trust that that's what they are doing. But we did build in these secondary endpoints to be able to go, okay, so these results tell us this much for kids, but what else can we learn from them as well? We've also tried very hard to think about how to involve pregnant women, and who knows how limited that opportunity is, despite the fact that pregnant women, if they come into hospital with Staph aureus bloodstream infection, will get offered the same antibiotics. Their ability to participate in clinical trials has been restricted, some of which makes some sense because of the history lessons that we've learned. Others of it makes no sense because it's really restricting because of the financial cost of insurance rather than the clinical need. And so we've really had to work to advocate to include pregnant participants as well. And so then I can say it's an extraordinary clinical trial. We're aiming for 7,000 participants, which is a mind-boggling number. We've got a novel layered consent model, which I'll quickly touch on. There are more than 125 sites now. There are consumer reference and Aboriginal advisory groups. We've got more than 4,000 participants globally, of which I think some of these numbers are just updated in a subsequent slide, but 169 children, 4 pregnant women, and 5% Aboriginal participants. So out of that 4,000, the number of kids is small. I get that, but the actual ability to generate the evidence is really powerful. In terms of layered consent, I don't know if anyone's used layered consent in the room. No. It's a really patient-centered approach to getting consent. And so they can choose which one they want to use. And so they might say, I'm really happy with a 5-page simplified consent form. Yep, where can I sign? More than happy to participate. It makes sense to me. Or they can say, I really want to watch the videos. And so they can get the information from videos. And if they really, really want to read that detailed 40, 50-page legal document, they're also able to access all of those. And so the ethics committee has approved this. And to be honest, it's made so much efficiency for recruitment of kids into the trial. It's, I think, running at 128 sites in 8 countries worldwide. We drive at the Kids Research Institute, the Consumer Reference Group, and the Consumer Reference Group has been incredibly powerful in their advice to the trial, such that we've actually gone back to the NHMRC for funding, and the consumer said to us, the 90-day mortality endpoint, yep, it's great scientifically, but that's not when our journey ended. That's not when we stopped having symptoms and didn't know who to call to and didn't know what was going on. We want to know what's happening in 6 and 12 months. And so we built that into our study design, and fortunately it was funded. And so we're really excited about being able to use that, but just that story of enabling the consumers to guide how we're designing the trial as well. We've got an Aboriginal advisory committee who are really working on how do we embed cultural awareness, cultural safety into good clinical practice for clinical trials. And so to be honest, this is cutting edge for hospital studies where we don't actually do a lot of that as part of our clinical trial practice. And so very exciting to be working on. And if anyone knows a future Aboriginal PhD student who would like to work on this, please send them my way for a conversation at least, because we have got funding for that position. So this is where we're up to with recruitment. There's almost 4,000 participants in the trial itself, but there's a registry that runs alongside with another 4,000. And this is where we're up to for kids, where we've got 306 in the platform, in the registry, and 170 in the platform. Something that's just hot off the press is that the trial for one of the one of the domains has actually stopped. The Data Safety Monitoring Board has found that there is an increased signal with acute kidney injury, and then we've met non-inferiority for the MSSA and PSSA components. What the DSMB did say as well was that we're actually not seeing any of that signal in children. We were like, oh, okay. And they said you should or could continue in children. So we're actually courageously, a little bit scarily, going forward and going to restart the trial next month in children for the PSSA and MSSA combined into one silo, whilst we're going to be reporting on their results for adults. And so this is not what we expected to be doing in the platform, but it's kind of given us the ability to do that and more. So hopefully I've shared a little bit about the innovation, looking at where we could go with clinical trials. The importance of collaboration, like building this global network, has not been a small task, but an absolute privilege to be able to work alongside adult researchers looking at best practice. It's scalable. We've actually got low middle income country settings being involved now, particularly South Africa, and more will come on board, probably Malaysia this year. An ethical evolution to have the whole of life, but also to use layered consent, and the idea of building an infrastructure. So these are just some of the many people involved in the Global Trial Steering Committee, and a huge shout out to Josh and Steve, who are really working behind the scenes. We have attracted a reasonable amount of funding. You can't do this without a lot of money, and each of the countries involved does have to get its own funding to be able to participate. And if you wanted to learn more, please reach out. And that's the end. Oh, and anyone has a great abstract that they would like to submit, I currently have the privilege of being the president of Whispered. And so invite you all to come to the Congress in Bangkok at the end of the year. And for those of you doing point of care research, you might come to Bangkok twice in the year. So it's a great place to go. So I'll wrap up there, and hopefully we have time for some questions.
Wow, that was fantastic, Asha. No, just a very exciting presentation. And I think Asha's clearly communicated ways of working, excitement in research questions, and also the importance of communication. Often I'm on a meeting with Asha and she's running off to the media, which most of us dread the thought of a journalist approaching us, but she's excited by that thought and really commits to not only like the engagement aspect, which you've talked about beautifully today, but also making sure that the information gets out, firstly to community, but also to the wider world as well. I'm pretty sure we're going to have lots of questions, and I'm just going to get up here, questions so far, but while we have a look, there was many questions I had for Asha, but I won't monopolise. But I think I'm quite interested to know from the STOP trial, what are the next steps in terms of both Kimberley and other remote communities in Australia? How is that research going to translate to policy and practice?
That's such a great question. So we've tried to embed the learnings from the STOP trial into the National Healthy Skin Guidelines so that people have access to that. And we've also used urban and remote frameworks. So the first edition was predominantly remote. So now we've kind of another part of our research group, which I haven't spoken to today, is really looking at the skin health needs for Aboriginal kids in cities. And between 60 and 80% of Aboriginal people actually live in our capital cities, and so have some of the same skin health needs. And so we've been able to identify that and build that into the guidelines. We also get contacted really frequently from many remote communities, like, we've got a scabies outbreak, we've got a lot of skin sores, can you share your guidance with us? And what I didn't talk about today is that all of our books also have an English version. So they might be in a very unique language group that's only specific to that particular population, but they have an English version, and then we make it available to those communities to do some co-design and translation. And they might want to incorporate their own artwork and their local photographs and photos of kids, or they may want to use it just as it is. And that's happened in Central Australia and a lot of the Queensland communities as well. So that's kind of the translation into practice. We also have, I talked about head lice. The median prevalence of head lice was 47% across the clinical trial. And so for me, that's a huge priority, because obviously itchy scalps lead to skin sores, lead to the same problems that we also see with scabies. So we have the opportunity, working with DFAT and MDGH, to yarn with community about what they would like to see for a clinical trial in the future. And we've managed to incorporate not just the focus on scabies, which is the primary focus, but also to bring in head lice. And so designing now quite a few different head lice trials. So watch this space. Everyone goes, why would you care about head lice? It's not even a primary healthcare problem. It's like a family problem. And it's a family problem that I think every parent in the audience has battled with. And having time-consuming strategies to deal with head lice when you've got 1 in 2 kids, having it at any one time doesn't really work. So that's some of the next steps. Yeah.
If you've got any questions, you say go to the microphone on the right and please put your questions. Yes.
Thanks very much, Asha. Do you have any tips for people who are just getting started in consumer engagement research or co-design?
Such a good question. And to be honest, on the SNAP trial, I'll just use this example. Back in 2018, 2019, when we were starting to think about applying for funding, I said, we really need consumers involved in this. And the rest of the investigators said, really? And so have tried to keep on learning my own skills to be able to figure out ways of involving them. I think we have some good protocols at the Kids Research Institute that very happy to share that can help with that. But I think the most important thing is looking out for consumers, because consumers really like being involved in research and wanting to bring their perspective to their healthcare. So asking those questions and looking out for those opportunities, building it into budgets, and then trying to think about if you're not really sure what to do, bring up someone like me and just have a yarn about it and say, oh, what did you do when you weren't sure what to do? And it might just solve some of those early problems. But I think the absolute critical first step is to think of the consumers as partners in your research. And once you think of them, they're going to be built in at different layers of what you're doing, and trying to maintain that communication. So in the SNAP trial, we have a Facebook page, and the consumers wanted a Facebook page. That's the mode of social media that they chose. And so we try and keep that updated with relevant information and share with participants that if they want to involve themselves in finding more about the SNAP trial, that's an avenue. So just listening and learning from them. And I don't think I have any smart tips, but I'm more than happy to share a coffee and talk about it at some point.
We have a question from John Caldor.
Thanks, Rebecca. Thanks, Asha. Yeah, you described this fantastic 10-year journey and the intensive effort with the big teams across the remote parts of Kimberley and the outcomes, and in terms of the impact on skin health. But you also really emphasised that you developed the own guidelines and your own understandings locally, and there are many other regions that may have similar issues. So it's a bit like Rebecca's question. It's like when we often think about the translation of research finding into guidelines, we typically say, well, the trial was done here and it's going to apply there. But you've really emphasised very strongly that that's not necessarily the case in a number of communities that have their own desire to have ownership of what happens next. So, and we do have Aboriginal community controlled higher level structures such as well, CAMS or Aqua and then Nacho. And so how do you sort of balance those two, that tension between generating that response, which you obviously can't go and do that stop trial and you don't want to do a stop trial in every set of regional communities. But how much does it have to be picked up? How do you make sure you get that balance right between what can be achieved at a local level about ownership, whereas what you really want to do is move ahead in as broad a scale as possible? Yeah, I mean, I don't have any idea really.
It's a great question, John. And I think something that I haven't at all touched on is the power of the ACCHO sector, so Aboriginal Community Controlled Health Organisations. And I think I've heard a lot in the last little while that NACCHO has a strong focus on skin and skin checks. And I think something that we have been able to implement through a different set of guidelines is the RHD Australia guidelines, where I actually wrote the primary prevention chapter and absolutely built in skin health for the first time. And that seems to have had a really important flow-on effect into rheumatic fever prevention through both NACCHO and the ACCHO sector picking up the importance of skin health, because it was self-evident. That's what they see coming into the clinic all the time. They don't see a lot of sore throats. So I didn't talk today about the START project, which Beck and I and a group of us here working on point of care work on. But that's, I think, another form of that sort of primary prevention component, rheumatic fever prevention. I think maintaining the humility as a researcher, that you can come up with great designs and great research, and you just have to keep on knocking on doors and trying to get your evidence into practice as quickly as possible, is something that I'm continuously learning on, and we don't get it right every time. So I don't think, I think the National Healthy Skin Guidelines have been adopted across Australia, which I think is great. We're monitoring how many times they get downloaded and how often they're getting used in all the different varieties, and get asked to speak to them quite frequently. The ability to then pick them up and use them locally has been quite powerful. And I'll just tell one story where I was in a remote community to do, I can't remember, a different study, and just happened to walk into the clinic room, and there on the wall, they'd created a poster out of the first edition of the National Healthy Skin Guidelines, and they'd pulled out what they thought were the key points and made their own poster, which was like such a delight to see that something you've produced has sort of gone on to another iteration beyond what you could do. So that was like a cool aspect. And I think we do hear from communities all the time. They go, yep, we found these resources, but we want to modify them. Are you okay with that? And to be honest, I need to be okay with that. Even if I'd love to sort of go, oh no, this is perfect and it's finished, it actually never is. You can always improve and always change, and it will always be modifiable for the community. So I think, John, it's a learning journey that none of us ever get to finishing, and I'm looking forward to the next phases.
If we've got any further questions, feel to jump up. I could ask Asha questions all day. You've alluded to it, just the project that we're working on. You've focused, I guess, on skin sores in your last few minutes. Can you talk a little bit about the role of throats and what needs to be done for prevention of rheumatic heart disease in terms of the throats?
Thank you, Beck. That's perfect. So in another one of our studies that I have to limit yourself to how many things you can talk about in one sort of talk. It's called The Missing Piece. And we were looking at, in school settings, what was the relative contribution of sore throats and skin sores for kids who progress on to get rheumatic fever? And so it's kind of that missing piece of evidence that we need to answer what the best practice primary prevention guidelines should look like. And what we found was that a maximum of 3% of clinic visits are for sore throats. So kids just don't go to the clinic for sore throat. It could be that they know they're going to get the BPG needle and it's painful and they don't want it. It could be that they've gotten used to the symptoms, that they get them regularly and they are relatively low grade, or it could be there's just so many other priorities that they never thought to mention it. So when we were in the school setting, we actually found using a co-designed, locally developed sore throat checklist that more kids than we thought of would have sore throat symptoms. So it was about actually 40% of the kids coming to school in this high rheumatic fever prevalence context with sore throats. And then when we used a point of care test, we actually found that a number of them had strep A detected. They hadn't told their parents, they hadn't taken the day off school. And so there's this huge amount of what we could potentially call subclinical, because it's not coming to the clinic's attention, sore throats and strep A disease. So what we're now doing is trying to work collaboratively with Nacho as one of the co-leads and with the Aboriginal Community Controlled Health sector to build in a study where we run the checklist in all the communities, and those who have any symptom will get a strep A point of care test, and then they'll go on to get treatment. And I think it could be a game changer for rheumatic fever prevention. I'm looking forward to finding out. It's taken a reasonable amount of time to get the, I guess, design right, to do the negotiation and consultation with communities, but we're hoping we'll be able to start in the next couple of months up in the Kimberley and then expand into the Northern Territory and then Queensland. So I guess that's an example of another study where we've found things we didn't expect to find. And I thought missing piece study, we were just going to say the skin's the most important thing. It's nothing to do with the sore throats. Let's kill that idea. It's all about the skin. And what I found was we really need to think about both of them together and think about the different strategies and pathways, how we can combine them where needed, but how we can use tools and new technologies to be able to address detection of strep A. So watch this space for the next studies.
I'm sure we'll invite Asha back once things have moved along to hear much more about that. I think we've come to the end of the seminar time, and just want to thank everyone for coming today, both physically and online. I think you could agree with me, it was a really interesting seminar. Thank you so much, Asha, and really appreciate you coming all the way to Sydney, and we do hope you have a lovely dinner tonight with your mother. It was lovely to meet her and your family. I think that personal approach is definitely the way forward. So on that note, I think we conclude, and everyone have a lovely afternoon. Thank you.